My name is Shashank Sinha, and I'm an advanced heart failure and transplant cardiologist at Inova Shar and Heart and Vascular at Inova Fairfax Hospital in Northern Virginia, where I'm an assistant professor of medical education at the University of Virginia School of Medicine and serve as the medical director of our cardiac intensive care unit in cardiology and director of the cardiovascular critical care research program.
I'm Bram Geller. I'm a critical care cardiologist at Maine Medical Center. I'm assistant professor of medicine at Tufts Medical School. I'm the director of the cardiac intensive care unit at Maine Medical Center and also serve as the director of the temporary mechanical circulatory support program.
Can you comment a little bit on training pathways for critical care cardiology and how they have evolved since you embarked on this endeavor? Which one did you ultimately choose and why? And then let's embellish a little bit on, what are some of the exploratory training pathways that are being considered as we discussed briefly in the manuscript.
In Figure 3, we highlight some of the training models for trainees interested in critical care. And there's quite a few possibilities and different directions trainees can take depending on their interest and the sequence they want to do things. In Figure 3, the top training is one of the common training pathways where somebody trains in cardiology and then spends 1 or 2 additional years training in critical care cardiology. The second option is doing critical care cardiology first, followed by later cardiology training, which is 2 years in critical care and then 3 years in cardiology. And then there's some other models that involve additional subspecialty training in advanced heart failure or interventional cardiology that also exist. And in the bottom portion of Figure 3, we highlight some proposed training paradigms of the future where cardiology and critical care aren't isolated, distinct fellowships, but they're kind of merged into one. And training from day one can focus on both cardiology and critical care cardiology. When I was in training, I ended up doing that first option, meaning cardiology followed by critical care. I debated about doing an additional subspecialty training, but in the end felt like I really wanted to devote my career to critical care cardiology. And there's some complexity in continuing expertise in multiple subspecialties that I thought would be challenging. And so I did cardiology followed by critical care, and I think that pathway for me worked well. But as I think this figure well illustrates, that there are other pathways, and I think depending on interests and availability, some of these may make more or less sense for an individual trainee. In Figure 4, we kind of highlight what about those folks that don't necessarily want to do extra years of clinical training and want to have a practice focus in cardiology without true kind of dual board certification. And this kind of training, I think, lends itself really nicely to level 2 CICUs. And I think in the prose of the manuscript, we highlight some of the advantages of such a model. But here we highlight how the third year of general fellowship can be spent really focusing on key concepts in the CICU and either doing that practice focus with or without another advanced subspecialty. And folks who get this training are then really well prepared to work in level 2 or 3 CICUs and work collaboratively, potentially in level 1 CICUs with critical care cardiologists as well.